Welcome to the training of the Breas Auto-EPAP algorithm, an algorithm which is implemented in the Vivo 1 through 3, Vivo 45 and 45 LS, as well as in the NIPI 4 and 4 Plus. Let's start with a general description of the Auto-EPAP algorithm. The Auto-EPAP algorithm is intended as an automatic adjustment of EPAP to keep the upper airways open. So the objective is to maintain adequate upper airway patency during non-invasive ventilation, so that ventilation is not impeded by the airway. There are a few reasons why clinicians would use PEEP or EPAP during mechanical ventilation. PEEP or EPAP can be used to prevent upper airway obstruction. PEEP and EPAP can be used to recruit lung area, and it can be used to overcome intrinsic PEEP. So there are multiple reasons why a clinician will set and titrate PEEP or EPAP. The Auto-EPAP algorithm will only act on one of those. The Auto-EPAP will help to maintain the upper airways open. PEEP settings to recruit lung areas or to overcome intrinsic PEEP have to be done manually by the clinician. Now, who can benefit from an Auto-EPAP? It's mainly those patients that also suffer from OSA, that have an obstructive component within their disease. COPD patients with chronic respiratory failure is a population where approximately 20% of them have so-called overlap syndrome or a combination of COPD with OSA. The vast majority of patients suffering from obesity hypoventilation syndrome also suffer from OSA. But also in neuromuscular diseases and restrictive thoracic disorders, literature has shown that there is presence of overlap or presence of OSA and problems with upper airway patency in a number of those patients. With the Auto-EPAP algorithm comes, of course, a number of new settings. Let's go over them one by one, starting with the general Auto-EPAP settings. So the settings which we will describe now will be present in all combinations of ventilation modes where Auto-EPAP is available. Of course, there is a setting to turn Auto-EPAP on or off with a default setting to off. Once you turn Auto-EPAP on, you will see that there are a number of settings which come up. And one of the settings, for example, is the EPAP step. The EPAP step, which can be set between 0.5 and 2 centimeters of water, will define how fast the EPAP will increase when an event is detected. So it can go from a slow increase of 0.5 centimeters of water for each step up to a larger step of 2 centimeters of water with a default value of 1. The ventilator would not only increase EPAP in case of event detection, but in case of normal breathing will also decrease the actual EPAP to a lower value. The ventilator has to know when, after what time period, the EPAP pressure is allowed to decrease. The time of normal breathing after which the EPAP will decrease is the so-called relax time. The relax time can be set anywhere between 2 and 12 minutes. The default value is 5. Assume that the relax time is set at 5 minutes. That means that after 5 minutes of normal breathing, the pressure will decrease with a fixed step of 0.5 centimeters of water. If another period of 5 minutes of normal breathing is detected afterwards, the EPAP pressure will once more decrease with half a centimeter of water. And this might continue until the lowest allowed EPAP pressure has been reached. In case the relax time is set to off, the actual EPAP will not decrease. Even after normal breathing, the EPAP will remain at the actual setting. And so EPAP with relax time off can only increase, or is only allowed to increase over time, but is not allowed to decrease. And then there is something which is called the pressure limit. The pressure limit, as we will see in one of the next slides, is a new setting which will indicate the highest pressure allowed during auto-EPAP treatment. When auto-EPAP is active, the actual EPAP will vary in between two settings, in between two limits, the so-called maximum EPAP and the minimum EPAP. The maximum EPAP is the highest EPAP which is allowed during treatment, where the minimum EPAP is of course the lowest EPAP value which is allowed to be used during the treatment. So the actual EPAP will vary in between those settings, and it will never go above the maximum EPAP setting, neither will it ever go below the minimum EPAP setting. When using auto-EPAP, we also change the way we program inspiration. The inspiratory phase, which we normally define by an IPAP setting, will now be defined by so-called pressure support setting. And the pressure support is the support pressure added on top of the actual EPAP. Pressure support will vary as a setting depending of course on the maximum pressure that can be generated by the particular device. But so when auto-EPAP is active, we change from, let's call it normal EPAP and IPAP, to a setting of min and max EPAP with a pressure support on top of the actual EPAP. The default value is 10 centimeters of water, meaning that the peak inspiratory pressure being delivered during inspiration will be 10 centimeters of water above the actual EPAP. When auto-EPAP is used in combination with target volume, that is of course a different picture, as now we're combining an algorithm which will change the expiratory pressure together with the well-known algorithm which will change the inspiratory pressure to reach the preset selected target volume. Just as under normal target volume settings where we use a maximum and a minimum IPAP or maximum and minimum pressure, we will now apply the same rules, but the wording will change. We will not talk about actual IPAP or inspiratory pressure, but we will talk about a maximum pressure support and a minimum pressure support, where similar to the former slide, pressure support is the pressure applied above or on top of the actual EPAP. So maximum and minimum pressure support are only shown when auto-EPAP is to be used in combination with target volume. The pressure support may vary between those two set values to reach the target volume. If you have two variable pressures, there might be a maximum EPAP together with a maximum pressure support, or an actually high EPAP in combination with a high pressure support might lead to a total high pressure. That high pressure can be limited by the pressure limit setting. So the pressure limit setting takes care about the fact that actual EPAP plus actual pressure support will not surpass a safety level set by the pressure limit setting. Once more, the pressure limit prevents the combination of EPAP and pressure support to reach a too high value. The pressure limit is not an alarm, but it's a safety which will allow for safety without disturbing the patient. It will not act as an alarm. The inspiratory pressure will seal at the pressure limit and the breath will be delivered at the pressure limit value, which is different compared to a high pressure alarm, where during a high pressure alarm, first of all, there will be an audible alarm after 3 consecutive breaths, but also, as you know, the high pressure alarm will terminate the breath and switch immediately from inspiration to expiration. The pressure limit will keep the inspiratory pressure at the pressure limit value and allow for continuing of inspiration. So as said, the pressure limit is not the same as a high pressure alarm. Here in this case, we'll look at different settings of the pressure limit. In this example, we have a setting of minimum EPAP of 2, maximum EPAP of 5, so allowing the EPAP to vary between 2 and 5 centimeters of water. We ask for a pressure support of 7 centimeters of water on top of the actual pressure, and in the first part, the pressure limit is put at 7. And what you will see here is that the breath is not completely delivered. The pressure limit blocks the actual inspiratory pressure at 7. Even with a pressure limit at 10, there is just a small delta of pressure of 5 centimeters of water between the actual EPAP and the allowed peak inspiratory pressure. Lowering it, of course, will not help to solve this case, but with a higher setting of the pressure limit, you see that the pressure can reach the desired inspiratory pressure. So it's important to put the pressure limit at a value allowing for a safe combination of actual expiratory pressure plus pressure support on top of that expiratory pressure. Here we have an overview of the different settings. So everything which we just mentioned, Auto-EPAP to deactivate or activate the algorithm with an on-off. The algorithm will allow the EPAP to change between two settable limits called maximum EPAP and minimum EPAP. During inspiration, there will be a constant pressure support above the actual variable EPAP, which is called pressure support. So the peak inspiratory pressure that will be reached during, let's say, pressure support ventilation with Auto-EPAP, the peak inspiratory pressure that will be reached will be the actual EPAP plus pressure support above or on top of EPAP. With a safety limit, not an alarm, once more, which is the pressure limit, the absolute maximum pressure that the algorithm or that is allowed to be reached. When we activate target volume, the pressure support setting the constant pressure support will be replaced by a window of pressure support, very similar to the normal target volume algorithm. So the fixed pressure support is being replaced by a window of pressure support defined by the combination of the minimum pressure support and the maximum pressure support. So this is really giving the algorithm the room to maneuver, either with Auto-EPAP as a sole setting or in combination with target volume. And then the ventilator can be programmed in a way so that the EPAP steps, the incremental pressure steps used to increase the EPAP in case of event detection, can be set to the clinically most relevant setting for the particular patient. And that can be done because of the severity of the events or to control and make the algorithm more comfortable for the patient, anywhere between 0.5 to 2 centimeters of water. And also the ventilator has to know and can be programmed on when to decrease the EPAP by setting the relax time, defining the period of normal breathing after which EPAP will decrease between 2 or 12-minute setting. So when and how will the EPAP pressure change during Auto-EPAP? First of all, the algorithm will become active after 30 patient-triggered breaths, or 2 minutes after the treatment has started. So for patients on a spontaneous mode, it will take 30 breaths before it starts. If the patient is triggering less breaths, has less spontaneous drive, the auto algorithm will kick in 2 minutes after start of treatment. And of course, it will automatically vary the EPAP between the two settable limits, which we just described. I told you that the EPAP and the algorithm will react on detection of certain events. And the first event that will be discussed is the presence of obstructive apnea. An obstructive apnea is defined as a flow reduction below 10% for a period of at least 10 seconds. If such an event is detected, the EPAP will increase after the resolution of the event. So we will wait for a spontaneous resolution of the event, and after that, during the normal breathing after the event, we will increase the EPAP. Why after the event? Well, simply because it doesn't make sense to increase the pressure during the apnea, because the fully collapsed airway will not be pushed open, let's call it, by an increase of EPAP. The pressure applied during expiratory pressure is not high enough to push a collapsed airway open. What we will do is we will increase the EPAP after the resolution to prevent from future collapses of the airway. Another event is the obstructive hypopnea. Hypopnea being defined as a flow reduction below 70% of the baseline for a 10-second duration. The action from the algorithm, the reaction from the algorithm will be slightly different, as it will increase the EPAP during the event. So during the presence of the hypopnea, during the 10-second period, there will be an increase in EPAP. The rationale there is that by increasing the EPAP during the hypopnea, we're aiming to prevent from a full collapse. So possibly a hypopnea could turn into an apnea, meaning a semi-closed airway could collapse completely, creating an apnea, and that collapse we try to prevent by increasing the EPAP during the hypopnea. Of course, there's also something like central apnea. Central apnea, again, is a reduction in respiratory drive, so there is no breathing, but the airway remains open. As the airway remains open, of course, there is no need to change the EPAP after or during such an event. So in case of central apnea detection, the EPAP will remain the same as before the event. And then, as said before, during or when normal breathing is detected, that will be followed most of the time by a decrease of EPAP. As said before, the increase in EPAP will be a setting, the EPAP step of 0.5, 1.5 or 2 centimeters of water. So that's up to the clinician to choose and set that. The decrease in EPAP after detection of normal breathing is always with a step of 0.5 centimeters of water or millibar. Of course, what can be set here with the relaxed time is the period of normal breathing after which the decrease in EPAP will occur. Let's take a closer look on how the algorithm classifies the different events. First of all, the ventilator will look for patient-triggered breaths. So are the breaths patient-triggered, or are there mandatory breaths only, being the backup breaths of the ventilator? In case there are patient-triggered breaths, we'll differentiate based on the flow signal, or better said, based on information retrieved from the flow sensor, which will be recalculated by the algorithm. But to make it clear, if the flow, which is the signal which is best visible, if the flow remains above 70% of the baseline of normal breathing, it's being classified as normal. If the flow signal basically drops below 70% of baseline, it's being classified as a hypopnea. In case there is an event without any patient-triggered breaths, so if there's only backup breaths, we come to the right-hand side of the slide. If during that event, without any patient-triggered breaths, the flow drops below 10% of the actual baseline flow of normal breathing, it's being classified as an obstructive apnea. If that is not the case, so if the flow is in between 70% and 10%, and the check for airway permittivity shows a permittivity above 60%, resulting in a relatively normal flow signal, the classification of the event will be central apnea. So the Auto-EPAP algorithm will display the apnea-hypopnea index on the ventilator and in the PC software, can be used with or without target volume. So as a standalone, let's call it, for example, pressure support with Auto-EPAP, or in combination with target volume, pressure support with target volume and Auto-EPAP. Of course, it's only possible to use it in pressure modes, with leak circuit, and in adult mode. It can't be used in MPV mode, it can't be used in SIMV mode, and it's also important to know that the Auto-EPAP algorithm is deactivating during the set ramp. So in summary, some of the unique selling points for the Breas Auto algorithm are the flexibility, while we allow clinicians to select the desired EPAP step. As some clinicians have mentioned to us that some algorithms are too fast, or other algorithms are sometimes too slow, or it's very patient dependent, where a patient is uncomfortable with too large steps of changing EPAP. The relaxed time, as said before, somewhere between 2 and 12 minutes, allows the clinician to also impact and select the desired period of normal breathing, after which the EPAP will decrease. Then the fact that it can be used as a standalone auto-EPAP in pressure modes, where, for example, ResMed IVAPs is to be used when you want to use auto-EPAP, and the auto-EPAP feature on the ResMed devices is not available as a standalone feature. But of course, we allow for full flexibility by also allowing the use of auto-EPAP in combination with target volume. Now I will show you some examples of the auto-EPAP function used on its own. As you see on the right hand side, when you turn auto-EPAP on, you have here on the screen of the Vivo 45, you have maximum and minimum EPAP which show up. Below auto-EPAP, the pressure limit is being shown. The inspiratory pressure is no longer there, it's grayed out, but replaced by the pressure support. And on page 2, you can set your EPAP step as well as relax time. Let's look at a theoretical model of an obstructive apnea. So first there is a period of normal breathing with stable EPAP and a stable peak inspiratory pressure, so a stable pressure support with this, which is the delta between the EPAP and the peak inspiratory pressure. So as you can see, the pressure support is stable throughout the whole period of normal breathing. Now an event occurs. In this occasion, if we look at the flow tracing, there is an obstructive apnea that will resolve automatically, and we will get back to a period of normal breathing. And within a few breaths after termination of the event, you will see that the EPAP, because of the obstructive apnea, will increase, and at the same time and with the same step, you will also see the inspiratory pressure increasing, as we will keep the pressure support, again the delta, the difference between EPAP and peak inspiratory pressure, will keep that constant to guarantee the same ventilation with the higher EPAP compared to the periods with the lower EPAP. So here you see that both increase at the same time, your expiratory pressure as well as your peak inspiratory pressure. So the pressure support is remaining constant, but the generated peak inspiratory pressure will be higher as the baseline, let's call it, as the EPAP has increased because of the obstructive event. Let's look at the next example, where we will simulate a hypopnea. It will be very similar, but not the same. Again, a period of normal breathing, stable EPAP, continuous pressure support, generating a straight line on the peak inspiratory pressure. Now, instead of an obstruction, we will create, or there will be a hypopnea with a reduction in flow. But as we said before, what we're aiming for now is that this drop basically continues and would end up in a flat line, in a complete collapse of the upper airways. So rather than waiting for the end of the event, we will, within the event, increase the EPAP, and consequently also, of course, the peak inspiratory pressure will increase with the same amount to keep the pressure support stable. But you will see that this occurs within the event. Both go up, normal breathing restores, and we will keep constant pressures during the normal breathing. So the difference between the obstructive apnea and the hypopnea is that with obstructive apnea, we had the pressure increase after the event. With hypopnea, in this case, we have the increase in EPAP within or during the event. Let's look at the central apnea. So again, the same starting scenario where we have detection of normal breathing. And then here, during a certain period of time, we still see flow. The flow is being generated by the backup breaths. So there is no patient effort. These breaths, where you can see they have a different shape, these breaths are no longer spontaneous breaths or triggered breaths, but they are backup breaths. And during that backup rate, we do have some flow as the airways are open. And so this is being classified as a central apnea, a problem with the respiratory drive, the respiratory command. During the event, the pressure remains stable, but also when the event is solved and there is again normal spontaneous breathing, you see that the EPAP is remaining constant, as there is no need to increase the EPAP. There will be no benefit from an increased EPAP to solve a central apnea. So during central apnea, pressure is maintained. What happens during normal breathing? Normal breathing occurs, and there is a certain period of time, as we said, the relaxed time, settable between 2 up to 12 minutes. If the set relaxed time, if the period of time set by the relaxed time setting has passed, which is in this case at this moment in time, the pressure will decrease with a fixed value of 0.5 centimeters of water. In this case, as you can see, the EPAP, the actual EPAP, has decreased down to the minimum EPAP level. So that means that now, despite further normal breathing, the EPAP will no longer decrease. If the value, the resulting value, would not be down to the minimum EPAP, but it would be somewhere above that, there is the possibility that after the similar period of time, the pressure would decrease again with half a centimeter of water. So during normal breathing, each time the selected relaxed time of 2, 5, 10 minutes, whatever the setting is, has passed, the EPAP will decrease with half a centimeter of water as long as it has not reached the minimum EPAP value. Let's now look at a new ventilation mode where the target volume algorithm gets combined with Auto-EPAP. Here on the right upper side, you can see that the settings have changed. So when we activate target volume, the pressure support, which was initially on the top here, has now disappeared and is being replaced by the minimum and maximum pressure support as discussed earlier on. For Auto-EPAP, you see similar settings on min and max EPAP as well as pressure limit. And of course on page 2, the same EPAP step and relax time are still available. Let's first of all look at what will happen during an obstructive apnea when a pressure mode is combined with target volume and Auto-EPAP. The graphs look a bit different now, as we will add the volume graph, which we will need to make sure the algorithm works, or to understand how the algorithm works for target volume, the flow graph to detect the obstructive events or the upper airway events, and then we look at the different pressure graphs, the expiratory pressure and the inspiratory pressure, which both of them will vary between a min and max EPAP and a min and max pressure support for the target volume. So initially our patient is breathing and generates nice and constant volumes, but then here there's an overshoot. The delivered volume is too high compared to the set target volume, which as a result will make the pressure support drop for the next breath to allow the volume to be aligned with the set target volume. In the next part of the example, what you see is the creation of an obstructive apnea, so a period of obstructive apnea where, of course, the delivered volumes will be very small, and those very small volumes will result in the IPAP or the pressure support increasing up to a certain value, and then the event ends where the volumes are again reaching target volume, so the pressure support will remain constant, and as a result of the upper airway event, the pressure, the expiratory pressure, will also increase. At the same time, to keep the pressure support constant, the same amount of increase from the EPAP pressure will also be translated to the pressure support, once again to keep the delta, to keep the pressure support, to keep the difference between EPAP and peak inspiratory pressure constant. Here in this case, creating again an overshoot in volume, which then once more will make the pressure support drop because of the target volume algorithm. Let's look at a very similar picture, but now with target volume and auto-EPAP combined in case of hypopnea. The same graphs, the volume graph with the dotted line representing the set target volume, the flow graph in red, and the pressure graphs with dark blue the EPAP and lighter blue the pressure support, both of them with their min and max limits. At the start of the recording, our patient is breathing spontaneously, and very similar to the previous case, we see all of a sudden there's an overshoot in volume for one or the other reason, which will only impact the pressure support. So you will see the pressure support drop a little bit, but remaining, of course, always in between the min and max. As this has no, or there's no impact, there's no event on the upper airway side, the EPAP again, once again, remains stable. What we see here is the occurrence of a hypopnea, as we've seen before. So the flow will gradually drop, resulting in a drop of tidal volume, which immediately, breath by breath, will result in an increase of pressure support because of the target volume algorithm. As we said before, in case of hypopnea, the auto-EPAP algorithm will react within the event, during the event. So during the event, we will see an increase in EPAP pressure, resulting also in an increase in maximum pressure or in pressure support to keep the delta constant. So this last increase is mainly due to this increase in EPAP. The event is being solved, EPAP remains stable. We're again on track for target volume, which remains stable. But of course, when the volumes exceed the set target volume, the breaths will be delivered at lower pressure support, to then at the end finally reaching set target volume again. So what is important to know is, in combination of target volume with Auto-EPAP, is that the EPAP will only be changed in case of upper airway events, whereas the pressure support will be constant and go together with the Auto-EPAP changes, but also might change because of events happening on the target volume side. So the pressure support might increase or decrease also in case there is an overshoot or an undershoot of the delivered tidal volume. Target volume and Auto-EPAP in case of central apnea. We're looking at the exact same graphs as on the previous slides. Once more, we start with our same example. So there is normal breathing with an overshoot, which will make the pressure support drop. A central apnea, as you remember from the previous slides, there is an open airway, so flow can pass, flow will be delivered, the flow of the backup breaths, most likely resulting in a little bit smaller tidal volumes, which will make the pressure support increase. The EPAP is stable and will remain constant and stable after the central apnea has been resolved. And here, once again, the drop in pressure support, which you're noticing, has nothing to do with any change of EPAP, but is only explained by the overshoot in volume compared to the set target volume. Now let's look at a case of target volume with Auto-EPAP, and you'll see it will be in case of hypopnea in this example, but where the pressure limits will play his role. At the start of the recording, again, it's the same example. There is an overshoot, creating a drop in pressure support. Now there is a hypopnea. Hypopnea is causing the tidal volume to decrease, which will lead to an increase of pressure support. But already at this point in time, the combination of the actual EPAP plus the pressure support on top hits the pressure limit. So even if the volume is not satisfying at this point in time, the pressure support will no longer increase as it has hit the pressure limit. And also, when the EPAP is increasing during the hypopnea, you would expect the pressure support to be constant. So you would suspect the peak inspiratory pressure to be higher at that point in time, but as it has reached the pressure limit, it can't increase anymore. The only thing it can do after this overshoot in volume is decrease, and now there's again some room to increase in case there would be any further event, either from the target volume algorithm or from the Auto-EPAP algorithm. When we look at the literature around Auto-EPAP, there is not so much available as of today. As you can see, we've listed here the 4 major trials which are published so far. In a nutshell, you could say that there is no difference in clinical outcome between a fixed or an automated EPAP when treating obstructive apneas and hypopneas. No additional safety issues have been found, and in some of the reports the patients indicate, or some of the patients indicate, that Auto-EPAP is a bit more comfortable. But it's important to know that there's only limited data available as of today on the usage of any Auto-EPAP algorithm. Here we have an example of the Auto-EPAP in our PC software. So what you see here, which you know, the pressure graphs, the flow graphs, which are the most important ones to look at. When you look at the flow graphs, you see a number of events being created. The first event here is the creation or the simulation of an obstructive apnea. So what you can see in the obstructive apnea, there's only very little flow going to the patient. The device runs on backup breaths, and you see the EPAP step of 1 centimeter of water. You see after the event an increase in EPAP. So the lower line is lifted, is elevated. Here is another obstructive apnea, very low patient flow. You see again after the event there is an increase in EPAP. Situation is different in this event. You can clearly see that the flow pattern is completely different during the event. This is a hypopnea which was simulated, where you can see that the pressure, the EPAP increase, is occurring during the event. And then lastly, there is a central apnea, an absence of triggering, resulting in high flows, but with absence of patient effort. It's running on backup rate, where you see that the EPAP pressure is remaining constant. And then, of course, after normal breathing, the pressure will decrease. And you see a decrease here. When the period is passed, you see another one here, another one here, and another one here. So every time the relaxed time has passed, the pressure drops. The relaxed time has passed, pressure drops. The relaxed time has passed, the pressure drops. What is important to know is that this drop in EPAP is the relaxed time for this drop is starting here, because the central apnea detection or a central apnea event is not classified as an event for the relaxed time. So it's the period of normal breathing plus central apnea time, which is allowing for a decrease in EPAP. This is a bit more complicated, as here we're combining Auto-EPAP with target volume. When we look at the pressure, you can see that at the start of the recording, the target volume is really increasing the inspiratory pressure breath by breath to deliver a stable tidal volume. Again, there's an obstructive apnea here, which will create an increase in EPAP pressure after the event. There is a hypopnea created here with a pressure increase during the event. There is a central apnea created here where the pressure remains stable, and all the time you see that the delta pressure is remaining stable and is working on the target volume algorithm. Here the test lung was opened, the compliance was changed. You see that the volumes are shooting up because of the simulated compliance change, making the pressure support drop. Here again, an hypopnea with a pressure increase, pressure is decreasing, again a central apnea with the corresponding pressure changes of both inspiratory pressures as well as expiratory pressures. As marketing materials, you have this PowerPoint presentation. Make sure to also familiarize yourself with the new settings with the simulator which is available. There is a leave behind, there is a specification sheet with a high-level explanation of the Auto-EPAP algorithm. with some of the initial graphs which you've seen in this presentation, and also a summary of the settings. Also, the demo files, which I've shown to you just a few seconds ago, are available for you to have a better view in the PC software on what's happening and to train yourself. So the new Breas Auto-EPAP, what is the elevator pitch? What is the take-home message? The Auto-EPAP algorithm aims to maintain adequate upper airway patency during an IV. It will increase EPAP after an obstructive apnea. It will increase EPAP during an obstructive hypopnea, and it has a couple of unique selling points, allowing for greater flexibility, as it can be used with and without target volume, and it allows the clinician to select and fine-tune the desired EPAP steps, the increase in EPAP, as well as the relax time, so defining the period of time after which the algorithm is allowed to decrease the EPAP. Thank you for listening and good luck.